Good afternoon, good evening. Thank you so much for joining us for the Mpox special briefing from AfricaCDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. Our main speaker is Dr. Jean Kaseya, the Director General of AfricaCDC, who will provide the situation analysis on Mpox. Over to you, DG.
Good morning, good afternoon, good evening to all of you, and thank you so much for joining this press conference today. I wanted to start by saying thank you so much to the US government and to Gavi for donating additional doses of vaccines. As you know, on Tuesday, we received additional doses, 50,000 doses to DRC from the US, and we received 15,000 doses from Gavi. That brings the total doses from the US to 60,000, 10,000 given to Nigeria and 50,000 given to DRC. Thank you so much. We are calling upon the US to continue to support by knowing that we need 10 million doses. While we'll congratulate them for this support, but we are reminding that the US is the first contributor for public health in the world and is also for the humanitarian response. And we are expecting more from them, not only for doses, but also for the $599 million that we need for the continental response. Now, let me come back to the epidemiological situation of Mpox in Africa. As you know, the next slide, please. Yes, I wanted you to see that from the first epidemiological week of 2022 to the 35th week of 2024, we already registered 46,862 cases. Just keep it in mind. Keep also in mind the 8,627 confirmed cases and 1,682 deaths. Why we are putting this slide? It's because it's important for us to remember that if we consider 2022 to date, all 5 AU African Union regions were affected. But if we move to the second slide, and second slide, please. This is the slide that is giving you the information for just 2024. You'll see from the week 1 to week 35 of 2024, because today is the 12th of September, we already registered 26,543 cases, of which 5,731 are confirmed, and unfortunately, we have 724 deaths. But what is the key information if we compare with the previous slide? You will see, if we combine data from week 1 of 2022 to week 35 of 2024, only in 2024, the total cases represent 56% of all cases that we have from 2022 to date. You'll see that confirmed cases are 66% in 2024 if we compare with the total from 2022 to date, and deaths 43%. It means only in 2024, the outbreak is becoming a major issue. And we have more than even what we had the two other years combined. It means 2022 and 2023. And this one is calling for a strong action if we want to stop this outbreak. Slide 3. The continent continues to observe a steady increase in new cases reported weekly. With improved surveillance, community awareness, and disease management, we are beginning to detect many more cases, which has resulted in a declining trend in case fatality rate, as you can see in the graph in your slide. In Epi Week 35, the continent reported, and this is critical information, if we compare Epi Week 35 to Epi Week 34, we have 3,160 new cases. And we have, and more important, 107 more deaths. Comparing Epi Week 34 to Epi Week 35. It means in 1 week, we lost 107 people. It's too much. It's not acceptable. And this death came from 11 out of 14 countries affected. They came from Burundi, Cameroon, Côte d'Ivoire, DRC, Gabon, Guinea, Kenya, Liberia, Nigeria, Uganda. These are countries affected. This outbreak seems to disproportionately affect children under 15 in DRC, with this group accounting for 42.7% of all cases reported in week 35. And we have the similar situation in CAR, Central African Republic, and Burundi, where children under 15 years accounted for 46 and 54% of all confirmed cases, respectively. This is what is giving an average of what you can see there, of around 41% of children under 15 being of all confirmed cases. And this figure, if you compare with previous figures, where we see even a decline in terms of percentage of children affected, it means the epidemiology of Mpox is also changing, because we can say those who are from 15, more than that, constitute around 59% of people affected by the disease. We can say the disease is affecting children, but it's also affecting adults. We need also to know that there are some vulnerable groups, like truck drivers. And we need to strengthen the cross-border surveillance, mostly along the northern corridor. This northern corridor is from the Mombasa in Kenya to Uganda, Rwanda, Burundi, and the eastern part of DRC. We need also to strengthen this cross-border surveillance in the central corridor, that is from Dar es Salaam to Zambia, Rwanda, Burundi, Uganda, and eastern part of DRC. We wanted also to share with you some critical indicators that we are following that are giving us an idea on if we are winning or not to date. The first indicator, as you can see, is the number of detected cases, suspected and confirmed cases. We provided this information to you. The second indicator is, out of these detected cases, how many samples did we collect for testing? The third one is the number of confirmed cases. And if we combine all of that, we are looking for two major indicators: the testing rate and the positive rate. The testing rate, as you can see, out of the 26,543 cases that we had, 14,000 were tested. That is giving us around 52.9 testing rate. It means we are not testing too much. The second indicator is what we call the test positivity rate. Among the 14,045 samples tested, we have 5,549 that are tested positive. That is giving us the positivity rate of 40.8%. It's clearly showing us that the continent not only is not adequately testing, but also we cannot rely on only confirmed cases for decision-making and response. Because there are so many reasons why a test is not positive. How the test was collected, how the sample was collected, how the sample was transported, the quality of the sample that landed to the laboratory, the capacity of the lab person who's doing this test, the machine that they are using. So many reasons that can lead for a sample that maybe came from a person who has Mpox but cannot be positive. AfricaCDC, with our partners, WHO and others, in the context of Africa, we rely mostly on the epidemiology to lead our response. What did we do last week till date to respond to this outbreak? As you know, we launched the Mpox Continental Preparedness and Response Plan, co-led by AfricaCDC and WHO. We are requesting around $600 million to respond to this outbreak and to ensure the preparedness to other countries that are at high risk. Let us share with you that this is the first time seeing all partners coming together with one continental coordination mechanism. Now that I'm speaking, I'm addressing you, we have all partners who sent their representatives based on the pillars where they are responsible, sitting with other colleagues in DRC, in one office, working together. Today, we don't have a plan coming from UNICEF, from WHO, from MSF, from AfricaCDC. We have only one plan we are talking about. What did we do again? We supported the strengthening of the surveillance and laboratory system. We provided the sequencing equipment and reagent to Burundi. It's the first time for Burundi to receive that. And I'm glad to share with you that I will be in Burundi in the next 2-3 days to meet the head of state, the minister, and all partners and communities to assess our response to this outbreak. We also provided sequencing equipment to Central African Republic. I was talking with the minister today, who was sharing with me his excitement to see that the national laboratory, for the first time, they have the capacity to do the sequencing, the genomic sequencing. And as you know, these capacities are not just for Mpox, they will remain as legacy at country level. We supported also DRC, the INRB, Institut National de Recherche Biomédicale. This is the main institute for research in DRC, with an automated liquid handling system to speed up testing and sequencing. Let me remind you also, thanks to support from MasterCard Foundation via AfricaCDC, DRC got 2 years ago the first genomic sequencing capacity. We currently are working with different partners to identify and shortlist Mpox testing solutions, including point-of-care test kits. As you know, we didn't provide antigen tests that are rapid tests for Mpox because what we still have are not giving us full satisfaction. And our teams are working tirelessly to see how we can have an antigen test very quickly. In terms of vaccine, I will stop there. We got 215,000 doses from European Union through the collaboration that AfricaCDC signed with ERA, this is the humanitarian agency of the European Union, and Bavarian Nordic. Out of these 215,000 doses, we delivered to DRC 200,000 doses, and we are working with other countries to get the emergency utilization authorization, emergency use authorization for them to receive this vaccine. We also got commitment from France for 100,000 doses, from Germany from 100,000 doses, from Spain for 100,000 doses, in addition to the commitment from Japan to provide around 3 million doses in Africa. I already spoke about donation that we got from Gavi, the 15,000 doses, and from the US, the 50,000 doses, complementing the 10,000 doses that they provided to Nigeria. We are still far from our objective. As you know, now we are not just talking about children, we are talking about adults. It means we need to have sufficient doses to close, to bridge the gap, and to ensure that we are protecting all Africans who are in need. Let me stop here and welcome your questions. And over to you, Margaret.
Thank you, DG. I'll take the first two questions that come from Felix from DRC. The first question is asking explanatory factors for the emergence of viral diseases. For example, Mpox, COVID. Why are there more viral diseases than bacterial diseases in the 21st century? The second question is on the strengths and weaknesses of the response to Mpox in DRC. What are some of those? Over to you, DG.
Sorry, I didn't follow you. I was taking note. Can you please repeat the question, please?
Right.
The first one?
So the first question, yes, from Felix is factors for the emergence of viral diseases. So it's asking why are there more viral diseases compared to bacterial diseases in the 21st century? The second question is asking the strengths and weaknesses of the response to Mpox in DRC.
The Mpox in DRC, as you saw in one of the presentations that we made previously, is mostly due to the mutation of the virus. In 2023, around May, June 2023, with the clade 1b that we saw. And when we compare, I have to say, we don't just have one outbreak. We have many outbreaks in one when we talk about Mpox. And you'll see studies that we conducted in DRC about the clade 1b that is affecting the eastern part of DRC, including Rwanda, Burundi, Uganda, and Kenya. You'll see that this clade 1b is a mutation of the virus that we had before. This is also what is alerting us when we say we need to stop this outbreak now because we don't know if we can get another mutation. When we started to talk about the outbreak in 2022, 2023 at global level, no one knew that we can have the clade 1b mid-2023. That one is a major factor of what we are experiencing today. And there are other reasons that are making this outbreak worse. As we say, around 40% of children in DRC are affected by malnutrition, and they are vulnerable. We also know that people with low immunity are vulnerable. We know that pregnant women are also vulnerable. And that one, especially in the context of insecurity, and is making the situation worse. I think we need to understand this issue on a more holistic way. And by addressing the Mpox outbreak, we need to see how to address all other factors that are driving this outbreak. I try to summarize everything in one. Back to you, Margaret.
Thank you, DG. Next is Janice. You have the floor.
Good afternoon. I had two questions, if I may. The first one was around Burundi. On the call on Friday, and I'm sorry, I missed a lot of what was said on Friday. I didn't have very good connection, but you were talking about the high number or percent of children in Burundi, and you were talking about maternity wards. And I was just trying to figure out if we are seeing any evidence of mother-to-child transmission in utero, and if that's something that is being monitored closely, and if we've actually seen that. I took from the conversation on Friday that you'd also spoken about the risk of a mother who is nursing. Obviously, the physical risk of if the mother has Mpox, then she's holding the baby close, and then there's that further risk once they're discharged and get into the broader community and have interaction with the rest of the family. So I understand that part, but I wasn't clear if you were also saying mother-to-child in utero transmission. And the other question I had was around what we're seeing in Kinshasa at the moment. With a city of such high population, my feeling is that that would be quite an accelerator risk. And I was just wondering if that is also your view, and if there are any other hotspots that you are very closely monitoring, where there's high population density and the clade 1b is still likely to spread to.
Thank you.
Thank you. I will answer, and then I will give opportunity to my colleagues who are in DRC, Dr. Nikes, to provide additional information. I don't know if Ngash is connected. Yes, regarding the maternal-child in utero transmission, we have evidence on that. We have evidence on that, and there are a number of studies that were conducted showing clearly that we have this transmission happening. We cannot give you out of the total cases that we have, mostly for children under 1, we cannot give you the percentage of this maternal-child in utero transmission, but we already evidenced that we need to continue to conduct more studies and to give you the percentage. You'll see in some regions, like in South Kivu, there is an area where children under 5 years represent 38% of total cases. Out of them, you have more babies. And these babies, how they are getting that? Mostly to this maternal-child in utero transmission. Second, breastfeeding. Third, contact with adults that are affected. I think, as we said, with Mpox, we are conducting a number of studies to also understand the epidemiology, not only of clade 1B, but also of clade 1A and clade 2, and how everything is in correlation. Dr. Nikes, can you please answer questions regarding the hotspot vis-a-vis the situation that we are facing in Kinshasa? Do we have Dr. Nikes connected?
He's not connected.
Okay. Yes, Kinshasa is a city of more than 10 million people. And you'll see we started to report more cases in Kinshasa. And as you saw from the 1st of September, the learners went back to school. And that means if all measures that the government is promoting, like self-protection, washing hands, distance, and also some other measures that we can have, we know that that one can affect the way the outbreak is moving in DRC, especially in Kinshasa. We are working closely with the government and the National Incident Management Team to follow up that situation in Kinshasa, to report back. For now, the hotspots that we are following are mostly Equateur in the northern part of DRC, South Kivu, Sankuru in Central, and we believe that if we manage to control the outbreak in this hotspot, we can also control outbreak in other places like Kinshasa. The first doses of vaccines that DRC received, they are giving priority in these 3 areas I'm talking about. Over to you, Margaret.
Thank you, DG. Next, we have Carmen from Politico. You have the floor.
Thank you so much for the opportunity. So I have a few questions. I was wondering if you have any breakdown of the type of clades that are causing the cases. Like, for example, in children, do you know what the percentage is of clade 1A versus clade 1B causing cases? And then my second question was, since you were talking about the outlook since 2022, I was wondering, do you feel now that there's something that, AfricaCDC and, others in this space could have done since sort of like 2022 or 2023 to avoid getting to the situation we're in today with this new mutation and this, like accelerating outbreak? Thank you.
Thank you. Over to you, DG.
Thank you. I'm informed that my colleagues from DRC are connected. Dr. Nikes, over to you for this question related to clade 1A and clade 1B to children, if we have any information, and then the second one. Over to you.
No, thanks so much, DG. Thank you for the question. We as AfricaCDC, just briefly, we've established a network for genomic sequencing, and that was established during COVID-19, the Pathogen Genomic Institute. We've sequenced during COVID more than 200,000 strains of SARS-CoV-2. We're leveraging on the same platform, really as a pioneer on this field, to use it for Mpox. I said currently, as the DJ mentioned in previous calls, there's currently really geographic spread of the virus. So primarily you find clade 1 in the Central Africa region and clade 2 in the West Africa region. The only country with those two clades is Cameroon. Now, data is not, we don't have enough data because we're now putting in place a system through our lab directorate to sequence more samples from confirmed cases from the 14 African Union member states. So the plan is there to really do minimum of 200 across the different member states that are affected. So to answer your questions, we have more cases of 1B, at least in the DRC, based on the data that we have from ENR-Bay, where the lab doing the genotyping, next generation sequencing is based. And they are also analyzing retrospectively more samples to be able to generate. And AfricaCDC established that laboratory under the leadership of His Excellency John Kaseya. So, and then from the country base, you also have a difference on the spread of clade 1B that you found mostly in the South Kivu versus 1A that you found in the Equateur, which are the hotspots of Mpox in the country. Thanks, and back to you, DJ.
Yes, thank you. Thank you so much. As the evidence that we have, the children are mostly affected by clade 1B. This is the evidence that we have. If you compare with other clades, you will not see the same trend. I think we need to continue to do more genomic sequencing. The ideal one would be to do, to have more capacity and to conduct all of these studies. But because we are just taking some samples, we cannot really give you the magnitude of everything. But based on the studies that we conducted, it's clade 1B that's affecting mostly children in Burundi, CAR, and the eastern part of DRC. If you compare with West Africa, except new countries like Guinea and Liberia, but other countries you see it's more adult because it's clade 2. Yes, Margaret, back to you.
Thank you, Digi. We'll take the next two from the chat box. Catley from The Guardian asks, could you confirm the clade of Mpox case in Guinea that was discussed last week? The second question is coming from Dorcas of BBC Africa. Did the vaccine dose donations come with syringes, needles that are needed to administer them? The second question is, has DRC rescheduled to begin vaccination on 2nd October instead of 8th October? Over to you, Digi.
Thank you. Regarding Guinea, we are still expecting the result from the genomic sequencing to know if this is clade 1B, 1A, or maybe clade 2. But if we see the epidemiology, we see the age of the child. We see also the history. We could think that it could be 1B, but let us wait for the genomic sequencing. In terms of vaccine, if the vaccine are coming with syringes. Most of the vaccine donations don't come with syringes. And we are working with UNICEF and a company we call Revital Healthcare in Kenya to supply with more syringes. And regarding the last question on DRC, if they are planning the change in terms of when the campaign can start, my colleagues who are working on daily basis with the DRC incident management team, they can answer. Colleagues in DRC, Dr. Nikes and others, can you please provide the answer to that?
No, excellent, DJ. Thanks so much, DJ. From the last meeting chaired by His Excellency, the Minister of Health, the information we gathered was that this is going to be in the first week of October. And you can recall there's a lot going on before vaccine administration, the micro plans. DRC is a pretty large country, so they want to be sure that everything is in place. And then we can really have a smooth movement of the vaccines to the provinces, and then ensuring that they are ready. We're aware that the training have started of the vaccinators, and also that the logistics is in place. The AfricaCDC staff are going to join the whole team at provincial level to be sure that we support the vaccination program there. So yes, that's going to be the first week of October, and we're going to update you as things unfold through the Director General. Thank you.
And as I committed to everyone, even to the Minister of DRC, I said I will attend the launch of this campaign. We are talking about Goma. I will be in Goma, and my commitment is still there. I will get vaccinated to show to African people and Congolese people that the vaccine is safe. And let us wait a few days for logistics to be in place, for the communication plan to be rolled out, and then we can start the campaign. Over to you. Yeah.
Thank you, DG. Next, we have Sarah from DVEX. Sarah, you have the floor.
I have a few questions. What percentage of the $600 million plan is currently funded? Second question is, given limitations around doses, could the recommendations around doses be changed so that people would receive one dose as opposed to two? And then finally, you mentioned that you would like to see efforts around the northern and central corridors strengthened. Can you elaborate on those efforts, what you would like to see? Thank you.
Thank you. Let's take the next one from Paul. Paul, you have the floor.
Yes, thank you very much. Still pushing, taking Sarah's question a little bit further on the $600 million. You've mentioned in the past what AfricaCDC has already released. In terms of these respective African countries, what direct financial commitments have they also made to support this initiative? Still staying on that issue of money, putting $600 million alone on Mpox, what are the expectations that these funds would also support in any way other public health emergency response? And if I could chip in a last question that is not related to the funding, which is directly related to the response, what is currently the average time gap between testing and the results becoming available, so that we can have a more real-time picture of how the outbreak is evolving? Thank you very much.
Thank you, Paul from Lancet. DG, over to you.
Yes, I will answer to two questions from Sarah, and the third one, the cross-border surveillance. I will ask my colleagues who are working with all countries. Let me remind you that today we have Dr. Ngashi, who's co-leading the incident management team, who's in CAR to work also on the cross-border surveillance and supporting the country. Then my colleagues, Dr. Nikes and others, they will answer this question. I will also answer the first question from Paul about how we are expecting this money to support other health emergencies, while my colleague, Dr. Nikes, will respond to the second question related to the testing rate and related issues. Yes, what is the percentage of the 600 million already? Let us be clear on that. We finalized the continental response plan last week, and we launched that on the 6th of September. We started to get some input after even launching that. We made some changes because we want this plan to reflect the reality of support, not only from partners, but also from member states. Now, we will start the active phase of fundraising. This active phase of fundraising started with some initial commitment that we got. I want first to thank our member state. As you know, they gave us $10.4 million remaining from COVID funds. But let me also thank MasterCard Foundation, because MasterCard Foundation provided $50 million, mostly to UNICEF and World Food Program, to support the logistics and communication for the rollout of the vaccination campaign. We also got $20 million in addition to 100,000 doses from Germany. I had a meeting with the Minister of Health from Germany on Monday, who was sharing with me this information, and we are following up. But we are discussing again with Germany to see if additional support, direct support, can be considered in addition to what they are giving through various mechanisms. We got $3 million from Netherlands, and we are negotiating now. As you know, there was a meeting, a pandemic fund meeting, and the commitment that we got, I think you saw the press release from AfricaCDC, congratulating pandemic fund, but requesting more. It means out of the $500 million for the round 2 of pandemic fund window, we are expecting to get, I don't want to give a specific amount of money, but sufficient, an important chunk of money from that one, but we are requesting also a special window of pandemic fund to support the Mpox response. We are also talking with our leaders, head of states. We got funding from some countries to support the national response. Let me remind that the $600 million is not for AfricaCDC, WHO, UNICEF. No, it's a combination of country needs based on the country response plan and technical support from partners that will help countries to better respond to this outbreak. We got like 10 million from DRC. The government of DRC pledged 10 million to support the response. And we know that we'll continue to advocate for more than that. I will fly to Burundi because I was also informed that the government of Burundi made around $2 million to support the response. And more important, I want to make it, AfricaCDC and WHO and all partners, because we are together, we are putting in place a dashboard. This dashboard will be updated on daily basis. This dashboard will give us information on who is giving what and where. If we have the US giving, as I saw, a commitment to provide 35 million, we'll know where this money is going and we'll reflect that in the dashboard. This is a way for us to be transparent. This is a way for us to be accountable. We'll also provide this dashboard for programmatic issues. We want you to know what are new cases, where are these new cases, and what is the response we are providing. This dashboard, we are finalizing that this week together with PATH, with WHO, AfricaCDC, and other partners who are involved. And I think by the next press conference, it will be available. Are we expecting to reduce number of doses based on limitation of doses? I think we saw the study that was released yesterday, talking about if you get 1 dose of vaccine, the protection is around 58%, but it's increasing if you get the 2 doses. Now, in DRC, they are planning to give 2 doses. The government made a clear decision for 2 doses. We don't want to compromise on protection of our people. We are talking with Bavarian Nordic for the tech transfer. We know we can get more doses from Africa. And for that, we want to continue with that policy of 2 doses to protect our African people. Do we think that this money can support other health issues? Of course, when we are strengthening the surveillance capacity of a country, when we are supporting the lab capacity of a specific country, when we are training people, all of that will contribute not only for Mpox, but for all other diseases. And our approach in AfricaCDC is to be ready. Using the legacy of Mpox, today many countries, they have genomic sequencing capacity from COVID, as I was saying about DRC. Now we are giving to Burundi the genomic sequencing capacity. We are giving to CAR the genomic sequencing capacity. We are training a number of people to be able to perform a number of functions. This is how we need to see it. In AfricaCDC, we say emergency is building the development vision that we have for Africa. Dr. Nikias and the team, I know you are with Mercy. Can you please answer this question on the cross-border surveillance and the testing rate? DRC colleagues, are you there? Okay, it seems that we lost our colleagues. On the cross-border surveillance, what will be the ideal solution will be the antigen test, the rapid test. Because we cannot pretend to test, to use the PCR, the qPCR test for all truck drivers, to everyone who's crossing the border. But what we are doing, because we don't have this capacity, not yet, what we are doing is to involve community health workers and to strengthen the case definition. By strengthening the case definition and involving community health workers well-trained, they can report all suspected cases. People crossing a border. And for all suspected cases, we are training health workers to collect samples and to send them to where it can be tested. This one is our approach now for cross-border surveillance, till when we can have the rapid test to start to test at the border of each country that we think could be at risk. The testing rate is a major issue. As we said, the testing rate is still low. You saw it. We say that clearly the testing rate is not helping us to say we are winning with this outbreak. We move from 52% that we have today at least 80%. Then we can say we are mostly accurate on the cases that we are confirming. At the same time, we need to build capacities of people doing the testing. We need to provide machines. As you saw, we went in Indonesia, they committed to give us 30 qPCR machines and reagent. We commanded around 20,000 cartridge for the Gen Expert and for PCR machines. And I got a request from CAR, they need 300 cartridge. We'll give them. They said for this, for 6 months, if they have this 300 cartridge, it will cover the national needs. Because we know that this cartridge we can receive that this week, we believe that we can cover some needs in Burundi, CAR, DRC, and other countries. I think we will do our best to increase capacity for testing, while we are also innovative to use the current capacity that we have to stop the outbreak. Over to you, Margaret.
Thank you, DG. Because of time, we have time for just one last question. Annette from Reuters, you have the floor.
Hi. So you said you were requesting $600 million. I was wondering, like, I think you said you're asking Germany for this money, but I just wanted to know, like, which other countries and organizations you're asking for this amount. And also in August, you said that CDC actually needed, the gap was 224. So why this increase? And another question is, could you explain how the pricing for vaccines will work? Will African countries have to pay the full price, or will they get a discount? And so how much money that could cost potentially? Thank you.
Thank you. Over to you, DJ.
Thank you so much. Let me first clarify that when we are requesting $600 million, vaccine price is not included in the $600 million. $600 million, it's really to support operations at country level. And it means, and to make it clear, our continental response plan is more than the $600 million because we need funding for vaccine. And money for these vaccines will come also from the advocacy that we are making. Some countries are providing additional doses of vaccines, and I'm informed that we'll have more countries providing. Others, they will provide funding through different channels to procure this vaccine. As we know, Gavi is also working for some doses that will land very soon in Africa. Who can provide funding we are looking for? Funding will come from everywhere. The first source of funding will be our member state, even if it will not cover all needs that we want. But the first source of funding will be our member state to show the leadership and the ownership to this response. But we know from experience that this funding will not cover maybe 10, 15% of our needs. Then the second source will be our traditional partners. It means bi and multilateral development partners. It means philanthropies. It means private sector in Africa and out of Africa. It means other institutions who think that they can contribute. And we said we have also mechanisms in place like pandemic fund. We are talking with them. We are talking with Gavi. And I was informed out of $500 million of the emergency fund that Gavi has, they will provide an important support to Mpox, part of this money. I'm also informed that, as we said, other partners, they started to provide support, they can do more. We advocate for more. If you want to know if I'm positive that we can raise the $600 million, I will say clearly, yes. Why I will say yes? Because this is time for Western countries to show that they learned from COVID and also from the public health emergency of international concern, Mpox, in 2022-2023. We don't want to come back again tomorrow to say, you again abandoned Africa. We want them to understand this lesson, to say it's time for them to rebuild the trust. As we know, the trust was broken between Western countries and Africa. It's really time for solidarity. It's really time to listen from us. And we also believe that doing the tech transfer, the transfer of technology in Africa, will reduce the price of vaccine by 80 or 90%. That one will help us also to have an affordable vaccine. Because today, this vaccine, the cost is still high and African countries cannot afford that. But if we do the transfer of technology and the vaccine price can be reduced by 90%, we are putting in place mechanisms to procure this vaccine and supply that to all African countries that are in need. I think for now, let us take date. Let us, from today till UN General Assembly, I will have a meeting with you in New York. I will tell you how much we got. And if we need additional effort, we'll do that. But keep my word, I'm positive that we'll get this money. Thank you.
And with that, we've come to the end of the briefing. I'll hand it over to you, DG, for your closing remarks.
Members of media, thank you so much for attending and for sharing broadly to African communities, but also the world, effort from all partners in Africa to stop this outbreak. Let us remind each other, it's not just an African issue, as some newspaper wrote, it's a global issue. You saw other countries are reporting cases in the world. In the past, we were saying, let us be ready for the next pandemic. But let me quote Dr. Tedros, the WHO Director General. The next pandemic is not about if, it's about when. And let me quote another person that I know very well, who's saying, why do we think about the unknown if we don't address the known today? It means if we don't address the pandemic, the issue of Mpox, we don't know what we can do if there is a pandemic tomorrow. We are committed to continue to support our member states. And I want to thank all of our member states for data sharing agreement with AfricaCDC. We'll continue to support our member states together with WHO and other partners who are involved in the Continental Response Plan. This Continental Response Plan is putting together 24 partners. And we are working tirelessly to learn how to stop an outbreak using a coordinated and efficient mechanism. I thank all of you. We'll meet next Thursday, because now we agree to have this meeting, this press conference every Thursday, to give us time to collect data, to analyze, and to give you accurate data. I thank you. Over to you.
Thank you for joining us. We'll be taking one-on-one calls during the week. See you next week.